One moment, guys. My computer's just a little in processing this. All right. All right, now you're live. Sarah, I think we can probably just take another minute for people to join and then get started.
That's great. And you'll bring up the slides when you want me to start?
Can you not see the slides at the moment?
I cannot see the slides.
You cannot.
Thank you. Can you see the slides now?
Yep.
And it's the correct slide?
Looks good.
Okay, presentation mode.
Yep.
Great.
Am I good to go, Laura? Or you want me to wait another minute or two?
I can't see how many people have joined, but I would say you're probably, we're at like 70. So if you want to get started in a slow move, by all means, feel free.
I'll wait one more minute. I'll wait one more minute. Good morning to everyone on the call, and welcome to the Multi-Regional Clinical Trial Center of Brigham and Women's Hospital and Harvard's Leaning In series, focusing on practical approaches to improving diversity in clinical trials. I'm Sarah White. I'm the Executive Director here at the MRCT Center. Before we get started, next slide, please, Laura. Just like to note that the views and findings expressed on the session today and in the guidance document that we'll talk about are those of the speakers and the authors and do not imply endorsement or reflect the views of the US FDA or the affiliated organization or entities of any member who contributed to the work. Individuals have served in their own capacity, and the MRCT Center is supported by voluntary contributions and grants. Next slide, please. This is the 5th session of the Learning In series, which has been developed to dive deeper into the practical approaches of improving diversity in clinical trials and is based on the MRCT Center's work in diversity. The recordings of the previous 4 sessions are available on our website. Next slide. Today's topic is data standards and analysis. I'm going to be providing a brief overview of the topic, and I'm really delighted to be here today with colleagues who have been involved in the MRCT Center's work in diversity and the diversity work group over the past 3 years, and I'll briefly introduce them now. Dr. Roberto Lewis-Fernández is Professor of Clinical Psychiatry at Columbia University. He is the Director of the New York State Center of Excellence for Cultural Competence and Hispanic Treatment Program and co-director of the Anxiety Disorder Clinic at the New York State Psychiatric Institute. His research develops culturally valid interventions and instruments to enhance patient engagement, reduce misdiagnosis, and help overcome disparities in the care of underserved cultural groups. Dr. Lewis-Fernández will discuss the importance of social determinants of mental health in clinically relevant research. Also joining us today is Dr. Steve Snappin. Dr. Snappin has had a long career as a biostatistician in the pharmaceutical industry, including 20 years at Merck and 15 years leading biostatistics at Amgen. He currently is an independent consultant at Seattle-Quilcene Biostatistics, and during his long career has led the biostatistical efforts of more than a dozen successful pharmaceutical products in multiple therapeutic areas. Steve's going to be discussing data analysis in diverse populations later in the session. Next slide, please. As a brief introduction to the MRCT Center, we are an academic research and policy center focused on addressing and improving the integrity, safety, and rigor of global clinical trials. We do our work by engaging and convening a diverse group of stakeholders, including industry, academia, government, nonprofit, patient, and patient advocacy, to define emerging issues and create and implement ethical, actionable, and practical solutions. Over the past decade, the MRCT Center's efforts have resulted in implementation of best practices, greater transparency, and improved safety for research participants. And on the next slide, you can see our website, and I'll also just note that our work is freely and openly available, and we routinely post news, events, and updates on both Twitter and LinkedIn. Next slide, please. In August of 2020, we released Achieving Diversity, Inclusion. Oh, Laura, could you just click once more? Thank you. We released Achieving Diversity, Inclusion, and Equity in Clinical Research, which is a comprehensive guidance document and toolkit that was really the culmination of a 3-year project that the MRCT Center took on to tackle diversity in clinical research from an ethical, scientific, and practical standpoint. The diversity work group was led by Richarde Araujo of the US FDA, Barbara Beer of the MRCT Center, Luther Clark of Merck, Milena Lolek of the US FDA, David Strauss of Columbia University, myself, and along with the amazing work of our internal team have created the document that you have access to today and that we have talked quite a bit about. I'd also like to note the invaluable contributions of our work group members, more than 50 who came from a wide variety of the workforce and really brought life to the guidance document. And we're incredibly grateful for their contributions and experience. Next slide. The guidance document and toolkit, which is almost 500 pages, provides a multi-stakeholder contribution and consensus. It sets forth practical and actionable recommendations, includes an accountability section that considers how each stakeholder can change the paradigm, and also is complemented by a toolkit that provides adaptable resources not easily found elsewhere. Next slide. Today, we tackle data standards and analysis. The average clinical trial generates about 3 million data points. However, in some or many cases, the collection of data variables, especially the demographic and non-demographic data variables in clinical research, overall lacks uniformity. This limits the ability to subsequently conduct secondary analysis or compare data across studies, also known as interoperability. And in the end, at the end of the study, the data analysis is very much dependent on the data collected. Next slide. Today, and in the guidance, we recognize 3 separate elements of data standards and analysis. At the ground level is the data collected and being collected at the most granular level. In data reporting, variables are grouped into biologically relevant categories that are frequently defined by regulatory agencies, funders, and other oversight bodies. And together, collection and reporting, or the data standards, inform data analysis. And grouping data into categories is done to achieve a more meaningful subgroup analysis. Laura, if you can click once, there are consequences for poor data collection, some of which include
At least I can't hear you, Sarah. I don't know if others can.
Agreed, Sarah. We lost your audio. You should be able to be heard now. Nope. Still can't hear you, sorry.
Can you hear me now?
Yes.
Awesome. Sorry. Apologies to everyone for that. Let me start at, I think I lost audio when we brought up this box of consequences of poor data collection. And so some of them are listed here on the slide. Data integrity, failure to reach outcome measures, misinformed analysis, and potentially a failed analysis. Next slide, please. So in the context of any trial, the demographic and non-demographic variables collected will depend on the disease and intervention being studied. For example, data variables you might collect for a novel treatment for a rare subtype of cancer may be different than the variables you may collect if the study is looking at depression in high-risk youth, which may again be different from those of a COVID-19 vaccine trial. The data variables should be predetermined and part of the study question. There should be careful consideration for the biological significance relating to those variables. And at study design, not only what specific data should be collected, but how the data should be collected should be considered, including everything from whether sites have adequate equipment, to whether participants will find the collection of data acceptable, even to whether there are country-specific limitations to what can be asked of participants. For example, you generally cannot ask for race in France. The study developers should be sensitive and aware of any regulatory authority, funder, or sponsor, or institutional requirements. Next slide. Data collection and reporting come with their own sets of challenges. Namely, there's a lack of standardization or uniformity in how they are collected and reported, as I've mentioned before. Chapter 11 in the guidance document describes these challenges as they relate to age, sex and gender, race and ethnicity, both in the US and globally. And so let's just walk around these boxes to identify what those challenges are. Very few variables are discrete or non-overlapping. Being pregnant or not pregnant is a good example, but most exist on a continuum. Gender, weight, or age are good examples. If the variable is discrete, it's obviously easy to categorize, but when you have a continuous variable, the buckets should be defined by biology or objective measures. I think we can all quickly think of and appreciate that sometimes these categories that get defined have been defined by other means, maybe through cultural, political, or historical lens, but we should always really consider what is the biological basis for this data variable and the subsequent categorization. In the examples, in the cases, variables, so I'm talking about variables that may be defined by cultural, political, or historical lens. the variables may be defined, named, and collected differently. So for example, race in one country may be termed ethnicity in another, or nationality in one country may be referred to as ancestry or citizenship in others. And when data is collected differently or categorized differently, and this happens routinely with race, but can also happen with something as simple as age, it limits the ability to combine the results and or conduct secondary analysis on the data. So next slide, please. And let's think a little bit more about age, because it's a very simple example. Age is a continuous variable and should be collected as date of birth when possible, although there are a number of countries that only allow you to collect age. Laura, if you can click once, depending on the disease or intervention, age can be categorized generally and is categorized generally with greater granularity at either end of the age spectrum. But depending on your research, you may want more granularity, say if you're studying growth hormone in adolescence, or if you're studying women in menopause. In these two cases, having more granularity around age can allow for more interoperability later on. Next slide. The CDISC, or Clinical Data Interchange Standards Consortium, creates data standards and controlled terminology for the collection of safety and efficacy, really with the goal of enabling data interoperability. The regulatory authorities and the US and Japan FDA require CDISC, and it's recommended in Europe and China. The Clinical Data Acquisition Standard Harmonization, or better known as CDASH, creates foundational standards that can be used to collect data consistently across studies and sponsors. And while CDISC has developed many standards and is used quite often, not all standards have been developed. Gender is one that we all recognize as needing future work, but it does set forth an excellent model for data collection and categorization. Next slide, please. As part of the diversity guidance and toolkit, we developed a 4-stage approach to data collection to assist study designers in identifying relevant demographic and non-demographic data elements, which are collected as part of the protocol. So briefly, just walking through these steps, the tool helps to identify which demographic and non-demographic variables should be collected for a specific protocol, the necessary level of granularity of the data in step 2, the standardized collection method, tool, and format for the data collection, and the last step, which is approaches to data aggregation for reporting. So this figure that you see is further annotated in the toolkit to provide guidance to the user in determining the relevant variables that are being collected as part of any protocol. Next slide. We have developed this data collection tool as a template for study designers as well, and it can be used when creating study-specific demographic data collection forms. The tool is largely derived from CDISC, except where noted. It's set up to be modified and used specifically for your protocol, and we've included a set of notes below the demographic variable fields to provide some additional clarity in collecting and categorizing the variables. Next slide. To complement that data collection tool, we also have created an aggregate reporting tool. And this is a model of how to categorize and report demographic information to regulatory authorities, oversight bodies, and clinical trial registries. Again, something that can be downloaded and modified depending on your specific protocol. Next slide. I'm planning to say very little about the concepts of data analysis and diverse populations, and instead I'm going to leave you in the very capable hands of Dr. Snappin, who's going to speak a little bit later in this hour. I will note that the guidance document does include an introductory focus on the traditional and novel approaches to data analysis. And I'll also draw your attention to the conference held in late 2020, the MRCT Center co-sponsored with the FDA, a virtual 2-day public conference on heterogeneity of treatment effects in clinical trials. And the recording is available at the link provided. Next slide. I will end my part of the presentation just thinking about diversity and the importance of clinical significance. Patients want to know if the intervention is going to work for them. And when we look at the study population, the more homogeneous it is, the more likely the results will apply to those exactly like them, but not a heterogeneous population. And on the flip side, the greater the diversity of the trial, the more variability and heterogeneity of the result, but the less applicability to the individual patient. And what matters in the end is whether an intervention works, whether the benefit is likely to outweigh the potential risk of harm, and that the healthcare provider is going to choose and prescribe an intervention, and the patient must trust the provider and the system. So with that, I am very pleased to now turn the presentation over to Dr. Lewis-Fernández.
Thank you very much, Sarah. Glad to be with you. Laura, could you pass to the next slide and to the next slide after that? So this is an overview of what I'm going to be talking about in about 15 minutes, I hope, which is I'm going to focus on one particular type of variable that can be very helpful for subgroup analysis, and that is social determinants of health. This is actually, you should say health. In this case, mental health is one of the specific examples. And the practical questions that I'll focus on are some of the ones that are related to what Sarah just mentioned. What do we need to know? What measures do we need? And how do we administer them? And these are very much linked, these questions, to the 4-stage approach that Sarah just went through, because that is a way of essentially a different way of answering similar questions, but a way of coming up with specific answers to these more general questions. Next slide, thank you. I'm going to focus on social determinants of health. This is a summary of the WHO definition. Social determinants are focus on understanding how the circumstances in which a person lives and works shape their health outcomes. And they're defined by WHO as those factors that impact upon health and well-being, circumstances of their lives, including the health system. And to remember that these circumstances are shaped by the distribution of resources, including money, power, at all sorts of levels, global, national, local, which are, of course, themselves influenced by politics and other elements. But in general, the idea of social determinants, the idea behind it is based on the notion of the social gradient. And that is, in public health, the notion that, or in sociology, the notion that individuals with lower social status have greater health risks and lower life expectancy than those with higher status, and that the impact of social position can accumulate over time. And I will give examples. Why am I talking about this? I'm going to give examples in the next few slides as to why paying attention to this kind of variable is important to trying to understand heterogeneity of treatment effects. I'm going to switch to the next slide, please. Thank you. This is a schematic that divides social determinants of health into these 5 categories. Now, there have been a number of such schematics, different ways of organizing social determinants. This is one that is comes from people who work with the WHO Sustainable Development Goals. And as such, I find it rather comprehensive and global, which I find to be an important aspect of the kind of work we all do, because increasingly intervention treatment research, even specifically, has been focused more and more on global markets and global samples, as it is very appropriate for it to be. And that introduces complexity and requires a global kind of thinking. And this, the outermost fringe here of this schematic, the one with the colored boxes, relates the different social determinants to different goals within the WHO Sustainable Development Goals, which are UN-based goals that all nations in the world are supposed to sign up for sustainable development. What I will mention here, focus you on, is number one, the life course approach, as emphasized by the circle with the different life stages. So this is meant to be a life course type of developmental process, as well as it being multi-level in the sense that there are distal factors and proximal factors within each set of type of social determinant of health. And the distal factors are also sometimes referred to as upstream factors and proximal factors as downstream factors. I hope you can read the slide well, and you can see examples of the different kinds of social determinants under each category. For example, under economic, the proximal factors include very granular elements like income and financial strain, unemployment, whereas the larger, more distal factors relate to economic recessions, economic inequalities, things that are at a larger macro level. All of them are important, and it's a temptation in health fields, particularly very applied health fields like medication research, to focus exclusively on the more proximal factors, but sometimes it's the distal factors like income inequality, for example, makes for a tremendous set of different kinds of important contributions that are often missed by the more individual level factors. Now, it's important to speak for a second about the question of causation, that causation, most of these studies are correlative, but they're meaning we don't know which, whether an illness or a treatment effect is caused by the condition or vice versa, more likely for illness and treatment effect. But there are ways to look at that. For example, under treatment conditions, you know when a treatment starts, and so it's easier to assign correlation, assign causation, but also there are longitudinal designs and other kinds of designs that can focus on causation for illness around these social determinants. Next slide, please. This next slide focuses on social determinants of mental health, and in particular highlights the mediational aspect of social determinants. For example, at the bottom level here in blue, you see more larger social elements that affect the distribution of opportunity and resources. And then you see how that distribution is filtered through different kinds of determinants that have to do with housing and living conditions, early life experiences like trauma or discrimination, education, unemployment, many different kinds of, different ways of categorizing these, but that because filtered these different ways of having opportunities affect a number of other factors. You see them in this pale blue one above the 4 boxes about reduced options, behavioral risk factors, stress responses, and so on, which then are the ones that produce in this case, mental health outcomes. And many of these have biologic type of mechanisms involved. For example, differences in access to opportunities or exposure to adversities can be mediated through concepts that are biological, like telomere length or allostatic load or cortisol dysregulation or inflammatory markers. All of these, for example, have been found to be pathways for the effect of discrimination on physical health or mental health in this case as well. And sometimes mental health has even greater impact from these social determinants than physical health. Next slide, please. Now that I've introduced to a fair extent social determinants, I want to proceed to the question of what is it that we need to know and how do you apply this information on social determinants to a particular study? And I'll focus my comments in the rest of the talk on the impact of social determinants on heterogeneity of treatment effects, HTE, which is something that I know that Steve will pick up later and is important for subgroup analysis. Can you click again, please? And it's very useful when you're choosing what do you need to know to anticipate factors that can clarify complex outcomes, like know in advance from preliminary work what sort of social determinants or other demographic or other types of variables we expect will be able to clarify outcomes such as heterogeneity of treatment effects, and then collect them in a parsimonious way to prepare for subgroup analyses. One of the ways to get out of the conundrum that Sarah presented earlier about the trade-offs between homogeneity of populations and heterogeneity or diversity of populations is to be able to conduct sufficient data gathering to be able to conduct subgroup analyses. And these are, Steve will discuss this, it's sometimes difficult to do, but it's very important if you want to, for example, address issues like heterogeneity of effects. And particularly if you need to supplement certain required data that might show results which are not easy to understand without additional information. For example, if you click again, race ethnicity often, race ethnicity is often associated with differences in treatment effect or other variables in studies. But what is it about race ethnicity that is causing these differences to arise? And is it the impact of racism on ethnic discrimination, so that race ethnicity is really coding the social and the impact of other people on the particularly discriminated individual? Is it genetic ancestry in some cases that is being lost as race ethnicity? Is it variations in exposure to adversity, which in a racialized society are associated with different markers of race ethnicity, or is it something else? So it's important to understand what we want to know when we're looking at race ethnicity, so that we collect that data too, those data too, in preparation for interpreting results. Next slide, please. Oh, sorry, next click. So therefore, we need to select a parsimonious list of social determinants, which isn't sometimes easy without a fair amount of preliminary work. Next slide. I'll give you an example, heterogeneity of treatment effects in asthma studies and how a social determinant of health could be very useful in clarifying some of the differences found in that area. And I'm going to refer to a study, it's referenced below by Starks, a recent systematic review of 30 cluster randomized trials which conducted subgroup analyses. Now, there are 30 studies on pulmonary disease, which also includes asthma in many of them, but not exclusively asthma. So these 30 are, I'm referencing particularly the ones on pulmonary disease. There are others in this literature review that I'm not going to be discussing, but out of those, because I'll focus on asthma and other related disorders, but with the 30 trials, 8 of them conducted subgroup analyses, although many more obtain the data that would allow them to conduct the subgroup analysis, but then they didn't actually report these, which is often one of the shortcomings of this type of work, that although investigators are mandated to obtain, say, age and gender and ethnicity, race ethnicity information, they don't always report it. Out of the 8 analyses, subgroup analyses that were reported in this review, however, 3 of them were positive, including one of the only one that conducted a demographic sub-analysis was found to be found that demographic variable to be a significant moderator of treatment effect. These are all of different interventions for pulmonary disease, including medications, behavioral interventions, and so on. That one demographic analysis focused on type of insurance. Patients with Medicaid insurance had greater effect than patients who had other types of insurance. This is a kind of social determinant that would be helpful in understanding heterogeneity of treatment effects and may be related to other aspects such as income, race, ethnicity, urban residence, and so on. There are multiple causes for the heterogeneity of treatment effect in asthma and other pulmonary diseases. You see them here, listed here. Next click, please. And I'm switching now to a different review by Taylor et al., which looked at interventions based on social determinants and how they may affect certain outcomes, meaning these are now interventions that try to manipulate social determinants and see the impact of that on health effects. And there were 3 asthma studies in this review that mostly was composed of improving the housing of individuals with asthma in order to see whether their asthma symptoms and so on would improve. And all of them found a significant improvement in one aspect of asthma health, either symptom score, severity, cost, healthcare visit, from the housing interventions. Next click, please. However, none of the 30 studies that focused on pulmonary health included anything on housing. So the recommendation, next click, would be to actually go ahead and include, it would be useful probably to include questions on housing, on studies related to asthma treatment, because it seems like changes in housing are important possible moderators for asthma care, meaning if you don't take into account the housing conditions of the population, you may not be clarifying the kinds of contributors that might be affecting the heterogeneity of effects. Next slide, please. Now, moving on to what measures do we need? The issue here is that there is a kind of a sweet spot between the number and the length of measures, because you can always get a lot of measures, but most studies don't have the ability to do that. However, so it's important ahead of time to know the particular area and pick parsimoniously a few social determinants that would be helpful to understand the treatment effects, such as I gave the example of housing for asthma. Sarah already mentioned certain general useful rules, like using continuous measures if possible. She gave the example of age. Next click, please. It's important that the measures not only be chosen carefully, but that they be locally valid, and it becomes rather difficult how to do that in large studies that cover many different communities. Sarah already mentioned race and ethnicity. However, the purpose here, the one solution is to obtain measures with sufficient granularity to make them valid locally, while at the same time being able to roll up those granular measures into the larger categories that, for example, US regulatory agencies require. So if you're going to do research in China, it doesn't make sense to just gather race and ethnicity as in Chinese or Asian, because most everybody in your sample would fit that category. It might, if you're going to study in China, for example, the impact of minority status, you might then collect information on Han and non-Han Chinese, and then be able to roll those up for reporting in an overall trial as Asian. But you would still be addressing the question about a discriminatory status, for example, as being a possible contributor to heterogeneity effects. The same thing with income, wealth, and financial strain. I'll mention that as an example in the next couple slides when talking about the toolkits. So there's a tension between harmonization and brevity, because many of the harmonized instruments like the NIH Toolkit, which has I'll go into it now, the Phoenix Toolkit has a whole set of measures on social determinants. Some of them are very lengthy, and there's an issue about how many of them you can do in any given study. I'll mention that in a second, as well as more brief measures. Next clip, please. Next slide. Here's the Phoenix Toolkit. It essentially shows that there is a core collection. You see that down below the blue there, the first black line again, down the second half of the page, is core collection. It has 16 measures that are considered central to an assessment of social determinants by the NIH. These are harmonized measures that have been developed by the NIH in this process to come up with measures everybody will agree with. They include, the core includes things like family income, employment status, food insecurity, as well as demographics, age, gender identity, and so on. And they're divided, in addition to the core, there's some specialty collections for individual level social determinants and structural level social determinants. Next click, please. Next slide. Here are the individual examples of the individual social determinants toolkits and the structural social determinants. These are only some of the examples. I believe actually it's all of the structural determinants fit into this one slide, but the individual are a total of 12 measures. Some of the individual ones repeat some of the ones in the core, but none of the structural ones are repeated from the core. As the titles indicate, the individual level are at an individual level. Each person, you're answering with the unit of analysis being the person. That's the unit of data gathering, I mean. And then the structural ones are more larger macro, more macro and meso level forces. And you can see here, for example, concentrated poverty refers to how much poverty there is in the neighborhood that the person lives in. So there's different community level, neighborhood level, social determinants that can also be used. The difficulty, of course, is how many of these would you be able to put into any given study? And my argument is that it will depend entirely on the purpose of the study and the domain, the theme, the topic of the study. I gave you the example for asthma, where I think housing, for example, and income, for example, are important indicators. In terms of income and so on, I'll just mention briefly that different instruments do it differently. They all address income in very different ways. I'll mention some other briefer versions in a minute, but the Phoenix toolkit covers this area in 3 different toolkits, one on income, one on wealth, and this one I mentioned on concentrated poverty. And so you have to choose. The wealth one, for example, is important for race ethnicity differences, where they have a much larger difference in wealth than in income, but it's a rather long toolkit. Next slide, please. The next slide gives you, the next 3 slides which I'll go through very quickly because of time. They give you different other alternatives for possible measures of social determinants that you can use. This one is from CMS, the Centers for Medicare and Medicaid Services. It's only 10 items, and it includes, for example, a single item on financial strain as one of the supplementary modules. Next slide, please. This one is from Health Begins, which is a consulting organization for healthcare topics founded in 2012. And this one has 14 domains with several questions each. You see the contents of the domains there. It includes 2 questions on financial strain, one of them being the same one as in the previous CMS measure. Next slide, please. And the final one is Prepare, which is developed by the National Association of Community Health Centers and their partners, which is a slightly longer, but still much briefer than the NIH toolkit. Again, it's not that I'm telling you to do one or the other. It's you have many options. It's just that some are longer than others. Next slide, please. I'm going to be finishing up with this one and then a conclusion slide. It's important to ensure the validity of the responses when you work on how to administer the measures. And if you click again, please, this comes in many ways. You can standardize the scripts so that the responses work for all the population. The way of administering the instrument works for all the population studied. You have to pay attention sometimes to the ordering of measures. So ethnicity needs to be asked before race. Otherwise, it's been studied quite a lot that Hispanic, Latinx patients or participants answer differently, whether you ask race before ethnicity or ethnicity before race. Next click, please. It's important to try to use trusted interviewers, people who make sense within the communities you're working with as people who are asking these questions in order to enhance validity. And finally, the next click is that it'd be good to conduct research, to have community involvement over time so that you have a relationship as investigators or an investigating company or agency with the population and are able to get more valid answers in this way. And think about this answer to an answer to the last question: what is in it for the community, not only the individuals? Because if you partner with community organizations, agencies, and so on, you will be able to get a lot more buy-in. And there are relatively simple ways that this can be done. For example, communities are very concerned that a new treatment will come out and they'll never have access to it. So how can you help get access to, offer access to the new treatment if it's successful to participants or members of their community, or engage with community organizations in different programs they run to enhance health, for example. These are all ways to show a good faith effort to improve the health of the community, not just use a community for selfish purposes or financial profit. Next slide is my conclusions. I hope I've shown the importance of social determinants of health as moderators and mediators of disease and treatment effects, how we need to think ahead to find the right domains and measures for each study and ways to administer it. There is a tension between parsimony and obtaining sufficient data to explain subgroup effects, for example, heterogeneity of treatment effects. And it's important to develop long-lasting relationships to maximize validity and engagement. Thank you very much. And now we're going to turn to Steve Snappin, who will focus on data, standards, and analysis.
Great. Thank you, Roberto. Diversity of clinical trial populations poses some important challenges for clinical trial sponsors. Due to these issues, there are some places where scientific objectives and sponsors' incentives don't always line up. As a brief outline of my presentation, I'll talk a little bit about the impact of diverse populations on power and sample size calculations at the design stage of a clinical trial. I'll go through a few examples of where heterogeneity of treatment effects have been observed and how they've been dealt with, and then move on to just briefly touch on a recent, somewhat innovative approach called shrinkage estimation that has a lot of appeal in dealing with this problem of heterogeneity of treatment effects.
Steve, can we just ask you to turn on your camera while you're talking?
And I thought I did, but the button, okay, I apologize for that. And I keep hitting the button and it turns on and then off. And now
We
it's
see you,
okay.
thank you.
Okay, great, okay. Sorry about that. Okay, so what's the problem with powering studies in diverse populations? Well, first of all, just a brief introduction to the concept of power. So power is the probability of obtaining a statistically significant result, generally designed for an overall population, if the drug works as expected. Now, there are two key factors that influence power. One of them is the between patient variability in the outcome measurement. So how similar or different are outcomes in patients in general, not talking about treatment effects, just in general, how different are the outcomes. And high variability makes it hard to separate signal from noise, and so leads to a larger sample size requirement to obtain the power that the sponsor wants. The second factor is the magnitude of the treatment benefit. Clearly, a drug that has a small benefit is going to require a larger sample size to detect that benefit than a drug that has a large benefit. And diversity can have an important impact on both of those factors, which I'll go into now. So first, on the next slide, now I'll introduce the concepts of prognostic factors and predictive factors. So a prognostic factor is one that's related to a patient's likely outcome. So suppose we're investigating a treatment that's meant to slow the progression of a disease, and time to progression is the primary outcome measurement. And you'll see my feeble attempt at an illustration of this concept below, where we've got a bell-shaped curve, a normal distribution of rates of progression among a population, where those little circles represent individual patients, and you see they vary. And it's the width of that population that has an impact on the sample size and power calculations. Now, in the next slide, what if that population of individuals consists of two different kinds of people? In this case, I'll split them into men in blue and women in red. But suppose that there's a difference in prognosis between those two groups of people. So the men tend to have slower rates of progression, women tend to have higher rates of progression. So that would be an illustration of a prognostic factor, where gender is a prognostic factor. And in the next slide, you can see that incorporating that diverse population leads to a larger or a greater amount of variability than in looking at a more homogeneous population. So the black curve represents the shape of the distribution or the width of the distribution in the diverse population, where the blue or the red represent what the variability would be in a homogeneous population of all men or in all women. And so the diverse population leads to greater variability, which leads to greater sample size requirement. Now, prognostic factors are important and do impact the sample size calculation, but they can be neutralized. And we have some tools for doing that. So at the design stage, if we have a strong prognostic factor, we can stratify the randomization. And at the analysis stage, we can do a stratified analysis, or we can do covariate adjustment. So we can deal with that issue actually fairly effectively, but it does require knowledge of which factors are prognostic. You need to plan for this ahead of time, and you need an accurate assessment of them, relating back to Sarah's comments on accurately assessing the patient's patient characteristics. Next slide. So that's a prognostic factor. A predictive factor, on the other hand, is one that's related to the likelihood of a treatment benefit. And when a factor is predictive, we observe differences in outcomes between subgroups, we refer to this situation as heterogeneity of treatment effects. Now, usually we don't account for HTE at the design stage. We generally assume a single magnitude of benefit that applies across the population, but we often observe heterogeneity at the analysis stage. And it's critically important to learn at the analysis stage whether heterogeneity of treatment effects exists. It's also important to distinguish between two types of heterogeneity, or at least statisticians tend to distinguish between them. One is where the treatment effect is effective in all subgroups, but to different degrees, and we refer to that as quantitative interaction. And then there's the more important case where the treatment is effective in some groups, but not effective at all, or even harmful in others, and we refer to that as qualitative interaction, clearly a more important one to detect and learn about. Okay, so just as a couple of examples from my experience where heterogeneity has been observed. So this is one that goes back a couple of decades. It was a trial in patients with heart failure looking at the beta blocker metoprolol, where at least for one important outcome, total mortality, so you can see in red, the results in the United States showed no benefit on overall mortality, while for the study as a whole, there was a fairly substantial benefit. And there was concern that there was something unique about a United States population such that the drug wasn't working in the same way in the United States as it was in countries outside of the United States. The next example is the Plato trial, somewhat more recent, but also one that got a lot of attention. This was a comparison of two antiplatelet treatments. Ticagrelor was being compared with the standard treatment clopidogrel. And again, I probably should have come up with examples that didn't all involve region, but in this case, it was also a regional difference that was observed, where again, the results in North America, primarily the United States, were quite different than the results in other regions of the world. And in fact, while the ticagrelor appeared to be superior in most regions in North America, it was the opposite, and clopidogrel appeared to be superior. So in this case, there was, again, apparent heterogeneity, and in this case, it appeared to be a qualitative interaction that we were observing. Next slide. But the problem is that we often observe apparent heterogeneity when it's not real. There have been there's been a lot of attention on this. There was a brilliant illustration of this fact by the researchers of the ISIS trial a while back, where they divided the patients by zodiac sign and showed important or apparent differences in response to the drug by zodiac sign. And so it's been clear that while it's very important to understand true heterogeneity, that clinical trials result in spurious heterogeneity very frequently, and cases of true heterogeneity can be swamped by these cases of spurious heterogeneity. And so it's very difficult to know that when you see heterogeneity, whether it's real or whether it's spurious. And that's been a great challenge for statisticians and clinical trial researchers over the years. Next slide. So recently, some Bayesian approach has been gaining some traction, and I think it's really quite promising to be using a Bayesian approach. I will first mention that, of course, there's always been a controversy around Bayesian methods. A Bayesian analysis of the trial results as a whole requires some kind of prior distribution for the magnitude of the treatment benefit. And that is where there's always been a lot of controversy. A Bayesian subgroup analysis, on the other hand, doesn't require a prior for how well the drug works. It only requires a prior for how consistent the drug effect is likely to be across subgroups. And that turns out, I think, to be a lot less controversial. In fact, and I won't go through the quotes that I pulled out here, but I think you can make a case that in this regard, everybody is a Bayesian, that there is no controversy, that even people who don't realize that they're using Bayesian prior are actually doing so in going into an analysis where they see heterogeneity and in using some prior belief that the drug really is likely to have a consistent effect across subgroups, and that it's likely that that the heterogeneity that we observe is probably spurious. Okay, so next slide, just to give a quick illustration of what these Bayesian shrinkage estimators do, is that they look at the observed results, and let's say I have two hypothetical subgroups that are shown, but with confidence intervals with the solid black line, and then they shrink the results, that is, pull them towards the overall result. And the dashed line represent confidence intervals after applying a shrinkage estimator, where the orange arrows are showing the result of the shrinkage, how the estimates move closer to each other. I won't go into details of how this works, but just go in the next slide and give a quick example of what if we were to apply shrinkage estimation to the Plato trial. So the Plato trial, the overall results that I presented before are again in the black, and it's in a different format, but these are the same results that I showed before, where the results in North America are in the opposite direction from the rest of the world. And now there's not just one shrinkage estimator you can apply. There's a lot of different factors that go into it, but I've applied one particular shrinkage estimator to these data. And what we get left with is estimates of the effect across regions, which are actually quite similar to each other. The shrinkage estimator that I've applied is one which goes into the analysis with the prior assumption that results around the world may differ, but North America and Europe tend to have similar effects, and drugs are likely to work similarly across North America and Europe, and therefore the results after the shrinkage estimation in North America and Europe are quite similar to each other. Next slide. So just to summarize, that many characteristics are prognostic effects, and these do have an impact on sample size calculations, but they're things that we can account for as part of the design of a clinical trial, and we account for them through stratified randomization and stratified analysis. Predictive effects, on the other hand, are ones where there's heterogeneity of treatment effects and the treatment works differently across subgroups. And that's a lot more challenging problem for clinical trial researchers. Detecting heterogeneity of treatment effects is critically important, but extremely difficult using standard methods. And shrinkage estimators have great potential to address this problem. So I'll hand it back to Sarah now for some final comments.
Thanks so much, Roberto and Steve, for your expertise in these areas and these presentations that were just incredibly on point to diversity in clinical trials. We are just about at the top of the hour. We do have, there are many questions, but I think what I'd like to do, if people are able to stay on for just a few extra minutes, is just pose one question to each of you to see, just to get a little bit of discussion. So Roberto, let me ask you first, and this may be something that you really just clarify coming out of your presentation too. In your opinion, what are the top social determinants of health variables that any clinical investigator, either at an academic institution or industry, should really be focused on? And kind of on piggybacking on that, what's the optimal amount of time that someone should spend collecting social determinants of health in any study?
Yes, thank you for the question. I'll try to answer briefly. The general point that I want to make is that it is hard to come up with blanket social determinants that are good for everybody, because it depends on the previous work done in that particular topic. That's why I privileged housing when it came to asthma conditions. But in general, if I had to pick for general categories, I think financial strain is one that I find very important. There are a few demographic indicators that are super important that are also regulated, so meaning regulatory required. So those are, you know, they have to be obtained. So it's good to obtain information to clarify them. I am partial to a quick assessment of discrimination, because it can be easily obtained with one or two questions, and that can often cover a whole range of possible life and other expectancies, other issues that affect. Something about adverse childhood experiences can be, if briefly asked, would be very useful. So essentially, social support. I know that I'm giving a longish list, but the idea is that it depends for which purpose and for which type of condition. It's most important. Social support has been found to predict, longevity from MI, prospectively, so different kinds of, it depends what you're looking at basically, and what is likely to affect the treatment that you're creating. I'd say 5 to 10 minutes, but that is because I find social determinants so important.
Yeah. And we could clearly have an entire session on just your answer to that question. Thank you. Steve, we'd love to hear from you. How do you select subgroups for analysis without bias?
Yeah, that's a great question. The quick answer to that, like to many statistical questions, is pre-specification. So we do, I think it's important to go into a trial at the planning stage and have a statistical analysis plan. The plan would list the different subgroups that you will look at. And so we don't pick the subgroups based on to present based on the data. The subgroups are presented based on the analysis plan. However, that doesn't completely solve the problem, because then you're still left with generally a long list of subgroups that we look at. And then our eyes go towards the one where the results are the most extreme, and that's where the problem lies. That that analyses of subgroups are completely unbiased. They give actually accurate representation of what the results are, but once you focus on the most extreme results, that's when you're likely to be misled, and that's what we do, and that's why the subgroup problem has been so difficult.
Thank you very much. Okay. I think at this moment, even though we could clearly keep talking for another hour, I would like to thank both the speakers and everyone that has joined the presentation today and stayed on for a couple extra minutes. So we look forward to seeing you all on the next Leaning In series, which is in 2 weeks. And I don't have the slide up, but there will certainly be advertisements. Thank you, Laura. So the next session will be January 27th, Stakeholder Roles and Responsibilities, and we look forward to seeing you all then. Thank you so much.